Hi there. I'm Dr. Kara Wallace here at St. Louis University. Can you guys give me a thumbs up if you can hear me? Oh, great. Perfect. Later on in my slideshow, in my presentation, I have a couple of videos that are pretty short, but when we get to that section, I'm going to just try playing them. And if you guys will just all wave your hands at me if for some reason you can't hear them. Normally when I present, I'm pretty interactive, but on this format, I've been told there's some potentially some problems in you guys connecting to me. But for those of you that don't have that problem, if you have questions, feel free to jump in and interrupt. And I'll leave a little bit of time at the end as well for some questions from you all. Again, I'm Dr. Kara Wallace. I'm in my third year here at St. Louis University. And prior to coming here, I was in Texas getting my PhD. And prior to that, I was a full-time hospice social worker I was full-time for 5 years and continued on PRN as a hospice social worker. And before my stint in hospice, I worked in the hospital setting. So I've got lots of experience doing some advanced care planning with folks toward the end of their lives. My research now really focuses on barriers to end-of-life care and how we can better connect people in a timely way to services at the end of life. So the presentation today, just a quick outline, we'll start with some introduction and background. And then we'll really talk about how to start the conversation personally within our own lives as professionals, as well as professionally. And then we'll go over some common advanced directive documents that you may or that likely you're familiar with, but hopefully you learned something new in a refresher as well. Just a brief overview of what our introduction covers here. Generally, when I talk to large groups of people, and because I'm an end-of-life researcher and come from hospice, I like to start by show of hands, asking people who is going to die one day, right? And so show of hands, and I always get a few hands, and then the rest of everyone else looks at me like this. Because it's not something that we really like to think about. It's not something that we like to talk about, but it's a common reality for us all, and certainly a common experience in that none of us actually gets to escape death, which is why I think it is so important to talk about and to plan for. It's also, I think, a professional reality. All of you all are training to be, I think, physicians, and you all will be working with people who are dying or working with people who are facing death. And so it's really important for us to gain some comfort in being able to talk about what goals of care look like and what people's wishes are as they approach the end of their lives. With that being said, I also recognize that it's really an emotionally charged time and that there are lots of challenges in having these kinds of conversations. I often think about the number of conversations that I've had with people professionally and how I've gained great comfort in being able to have this conversation. And then when I think about having the conversation with those who are close to me, sometimes that is even more difficult for me because of the emotions that are involved there. So I think it's important to recognize and to remember that as we enter into this conversation with people professionally. I think it's important to take kind of a look back and thinking about why really is advanced care planning important. And generally in the general population, there are a lot of people who are still dying within the hospital. If we look back 100 years, people were dying at the home. Within the home, people were familiar with death. And now with greater technology and with greater just the availability of assistance within hospitals, we feel a little bit more removed from death personally, and we don't experience death until later in our lives often. And I think that there's a fear for many people that emphasizing end-of-life care is the same thing as meaning no care, or that there's a failure within thinking about the end of our lives, which is just not true. But I think it's just important to look back in terms of how things have changed and why we have greater difficulty talking about death. And part of that is about how much later we experience it and how much longer we're living and how much more removed we feel from it often. It's also important to recognize the context of the fact that we live in an aging population. People are getting older, and so there's a growth in the need for end-of-life services, and really timely access in terms of when it's appropriate to start this conversation is really difficult. I think that's the other piece of context that's important to recognize. When we think about disease trajectory, and I've got a couple of examples here, again, historically, people used to get sick and then die fairly quickly, which is that black line, which also often we can see with diseases like cancer, where we, once treatment no longer is working, we can typically, there's a progression that we would recognize and be able to predict a little bit easier than some of the more chronic illnesses, which is really how most people die today. I think if you look at the top 10 ways that people die in the United States, 7 of the 10 of them are related to chronic illness. And so it becomes very difficult for us to pinpoint, well, when should we be having this conversation? Or when is it really appropriate to be talking about end-of-life wishes? Because it's really hard to predict where they are on that trajectory when we see lots of lows and highs, right? So both of those trends, I think, are important, recognizing that we have an aging population and also recognizing that it's difficult to pinpoint the timing of these kinds of conversations. When I talk about advanced care planning, I think it's important to also think about the role of palliative care and hospice care and recognizing what services are available. And these are likely things you guys are familiar with, and hopefully you get lots of experience and exposure to both palliative care and hospice care in your training. But there's lots of research that suggests the benefits of both palliative care and hospice care at the end of people's lives, both in saving money and in improving outcomes. And really, without specialized end-of-life care, patients are often receiving unnecessary or aggressive care at the end of life, and they're often experiencing a great deal of pain. The thing that actually brought me back to school for my PhD as a hospice social worker was seeing the amount of barriers that people face often in accessing end-of-life care. And I was often frustrated by the fact that people would come to hospice at the very, very end, maybe the final hours, final days. 1 in every 3 patients is dead within a week. 1 in every 2 is dead within about, I think, 22 days now is I think the latest statistic. So people really aren't benefiting from full scope of what end-of-life care or specialized services can really offer them. And that was a great frustration to me. Palliative care improves end-of-life quality. There's often less aggressive treatments that are used. There's fewer ER visits, fewer hospital admissions, and fewer hospital deaths by patients who are utilizing palliative care. Yet we know that there are still great barriers to palliative care. Oftentimes, not just doctors, I would say providers overall, still associate palliative care with hospice, thinking that they're the same thing. Or that palliative care must mean the very end, or that there's a loss of hope or failure in referring to something like palliative care. And I think so much of our training, is about helping people get stronger and helping people get better. And then when we introduce ideas of palliative care or hospice, I think the fear is that people see that as the very end, and that pushes our desire to talk about these kinds of services. Also, there's lots of research that shows that patients have a very limited knowledge of palliative care. I've been a part of a really interesting study here at SLU where we've been doing some interviews with African-American patients in dyads with their African-American breast cancer patients in dyads with their caregivers. And these are all patients who are post-treatment and post-surgery. And one of the things that we've been talking about them with is about how much communication would they like about end-of-life care services, even if they're not in a place to necessarily access them yet. And as well as just communication about their illness and treatment in general. And all 15 dyads that we talked to, there was not a single person who had had conversations about palliative care, yet every single one of them was would have been interested in accessing palliative care alongside their curative treatment once they learned what palliative care was. So it's just another indication that we're really not having these kinds of conversations, and patients in the general public are still not sure what palliative care is. When I was doing my dissertation and I was talking to my chair, who really didn't have a background in hospice care, and I would try to tell her about my frustrations with how late patients would come to hospice, her immediate reaction to me was, well, why would you want to be on hospice care for longer than a few days, right? And so I really had to do some education with her about why longer hospice care and more specialized care for longer periods of time was a benefit. And here's just a few of the things that I talked with her about. A lot of people think that hospice equals death. I think that's a general perception, which obviously in a lot of cases is true. But what's not talked about is that, there's been these large Medicare studies that compare patients on hospice and not on hospice, and they match them by age, diagnosis, race, gender. And it's the hospice group that actually ends up living a little bit longer than those without hospice care. And part of that is just because of the nature of the care. It's within the home, the focus on comfort, and patients aren't going in and out of the hospital, and all of those things can contribute to that longer rate of survival. And really, I think also the increased quality of the death experience, better symptom management. There are studies that show that families have a better bereavement when their loved one has been under the care of hospice. And there's also studies that show that hospice care is actually more cost effective than when compared to patients not on hospice. And again, a lot of that is tied to do with trips in and out of the ER in the hospital. So I think it's useful to just remember when we're thinking about end-of-life care, really what benefits there are for that. And all of that is useful within the context of advanced care planning. And I think all of that is a part of being able to reframe what end-of-life care means and looks like. Because to a lot of our patients and our families, they hear the word palliative or hospice care and they automatically think the end. And so having the framework to be able to talk about what the real picture is in terms of accessing care and the outcomes and the benefits of that care can be a really useful way of reframing both of those types of care in our conversations. So we also know, just like with palliative care, there's lots of barriers to hospice. Certainly with hospice care, there's the added barrier of eligibility and election, knowing that patients can't access both curative care and hospice care at the same time with hospice. And again, we already talked about difficulty kind of in establishing at what point is this conversation appropriate. That's particularly true within hospice care, and that there's that 6-month prognosis mark, and identifying that is certainly difficult. I think this next barrier is particularly important within the context of advanced care planning, right? In that there's still evidence that we live in somewhat of a death-denying culture, although I think there's also evidence to the contrary, and that we're talking about this more publicly. But it's still really hard to have these kinds of conversations, both within our own families as well as professionally within health communication. And there's lots of evidence that suggests that. There's also lots of cultural barriers to hospice. 82% of hospice patients are Caucasian, and there's lots of reasons for a variety of minority populations not accessing hospice care, and that's certainly a problem as well. So what then is the role of advanced care planning related to all of this? Advanced care planning can really help patients and their families identify what their wishes are related to future care. When I talk about how late patients are coming to end-of-life care, it's a lot of the times because they've never had to think about it. They've never really thought about what their wishes would be if they were to be in these kinds of situations. And then they're not having the conversation until they're really, really sick to where they have no other choice. Patients who complete advanced care planning are actually more likely to utilize palliative care. And we know that palliative care has great outcomes. So it makes sense that we should be having better conversations earlier to help people access the services that they need at an earlier time. It's also important to note, certainly, that providers and physicians can now be reimbursed for having these kinds of conversations. And I think one of the barriers to having these conversations is knowing how timely they are. And hopefully the ability to be reimbursed for them will help overcome that barrier. So what is advanced care planning? Advanced care planning is really about planning for the what ifs that may occur across the entire lifespan. And again, these are just several different definitions, but it's not about a one-time event, right? It's about an ongoing process of dialogue. It's not something that you do once and you check off a list and then you're done. It's really about starting early and having the conversation multiple times. And as professionals, I think we play a really large role in introducing this process and helping families and helping to facilitate this conversation within patients and their loved ones, right? A comprehensive care plan that considers an individual's social support, preferences, and likely trajectory. And I think all of those pieces are really important. Advanced care planning can alleviate unnecessary suffering. It can improve quality of care and provide a better understanding of decision-making challenges facing individuals and their caregivers. For those of you that like pictures better than words, there's a couple of diagrams here. And really, I think the purpose is showing that it's really not too early to ever start this conversation about what our wishes are, and that we can start that here in the yellow when we're healthy and independent, right? And obviously, the conversation has to be revisited at different times during the process because values and wishes can certainly change at different points along the continuum. Just another way of looking at this. This is actually from the Conversation Project, which I'll get into in a second as a resource. But I like that this chart shows, if you can see this section here, when you're healthy, that's the time to be expressing, speaking, and documenting what your goals and wishes are. Because if we miss out on this piece in the orange, then when we get to this part of our lives where we're living with chronic illness and we're approaching the end of our lives, it's really hard for our wishes to be respected or accessed or implemented if we haven't expressed, spoken, and documented what those actually are. So as professionals, I think often some of our questions are, well, how do I actually do this? How do I actually talk with someone about what their wishes are at the end of life? And the timing of that, right, which I hopefully am addressing already in some of my comments soon and early. But when should I actually have these discussions with patients? And really, what does advanced care planning actually involve? So hopefully by the end of our presentation today, you'll have some ideas about how to answer these questions. Ultimately, the conversation starts with you. And I mean that beyond the conversation professionally with patients and families. I mean that within your own lives. I think it can be really difficult for us to think about how to have these conversations with patients and families if we haven't really given much consideration to advanced care planning within our own lives. And so that's a challenge that I have for you all, is to think about your own wishes personally. And so that's what I'll talk about a little bit here within starting the conversation. There is research, this one I've cited here is a little bit dated, but there's research that there's a lack of formal conversation within providers and their own families. And there's always mixed range of professionals who, you know, may be practicing, but who haven't completed their own advanced care planning. Physicians who do complete their own advanced care planning don't necessarily believe that overall acceptance of advanced directives will result in less aggressive care. And there is some research that suggests that just the completion of documents alone doesn't necessarily equate to the follow-through of those documents, which we'll talk about further. But it really, you know, raises questions. This particular statistic makes us think, you know, even when we've made decisions for ourselves personally, we're not always practicing with the same values that we have for ourselves in terms of having conversations early with patients and families, right? Even when we're kind of sure about our own values for ourselves personally. There's a recent study that I've been a part of, or that we've done here in St. Louis, really wanting to look at the connection between providers' own experiences of loss and death, and whether or not there's a connection between those experiences of loss and death and their own personal completion of advanced care planning. And not only the completion of advanced directives, but also communication with their loved ones and communication with their providers, in addition to any potential connections with their professional practice related to advanced care planning and end-of-life care. So I'd like to share just briefly a little bit about that. Here's were the three categories that we looked at. We did a survey and we had 190, I think, was our final number of professionals complete our survey. And these are physicians, nurses, social workers. We even had some speech, OT, some therapists. It was a much smaller sample. Our largest sample were physicians, social workers, and nurses. And again, they answered questions about their own personal experiences of loss, which involved personal experience caring for the dying, personal palliative care experiences or personal hospice experiences that they defined as helpful. And then we asked them if they had completed their own advanced care planning. We also asked if they'd communicated with family and or providers about what their wishes were in their advanced care planning process. And then we gave some standardized surveys related to effective end-of-life care delivery, and a survey related to patient and family-centered communication. And we asked about their likelihood to refer patients to both palliative care and hospice care. And I don't want to take a lot of time on this, but I just really want to highlight some of the connections that we found. First, between people who had experienced, had personal experience caring for dying, were actually more likely to complete their own advanced care directives, which makes sense. I think that there's this connection between what we've experienced personally and then actually defining what it is that we want for ourselves after having gone through those experiences. And not only was there that connection with the completion of documents, but there was also that connection between people who were communicating with their own families and their own providers based on those personal experiences caring for the dying. The next category that we looked at was these experiences of loss, right here, as well as the professional practices. So I think as clinicians, we're often taught to separate our own personal experiences from our professional practice, right? And I think that that's, as someone who teaches our values and ethics class here at SLU with graduate social work students, I think that there's a lot of value in being able to separate those things. But I think that inevitably we are impacted by our own history and our own stories, and that there's great value in thinking about those connections. And I think that tapping into those connections and reflecting on those connections can actually make us better clinicians. And I think that this data supports that. Basically, those with personal experience caring for the dying, there were connections between those with personal experience caring for the dying had higher scores on effective end-of-life care delivery and on patient and family-centered communication than those without those personal experiences. They were also more likely to refer to hospice than those without personal experiences. And then if you look at the bottom, those with personal palliative care experiences and personal hospice experiences, which were helpful, were more likely to refer to those services than those without those. And so I'm certainly a big advocate for professionals being exposed to palliative care and hospice during practice, because I think it can really go a long way in starting to overcome some of the barriers that I talked about earlier in terms of what we think hospice means or what we think palliative care means. there's research that suggests experiencing hospice or experiencing palliative care can actually change the meaning of those for people. And again, I think patients and families look to providers to help them in understanding available services. And I think being able to reframe those is a really important part of helping people to be able to access them when they're needed. Then we looked at, the last thing that we looked at was connections between as providers, our own personal advanced care planning processes, and whether there were connections with professional practices. And you can see here at the top, personal advanced care completion. So this is of any advanced directive, which again, we'll talk about those in a few minutes. Scored higher, people who had completed any advanced directive scored higher on effective end-of-life care delivery and patient and family-centered communication than those who had not completed advanced care directives. And while we didn't look at the reasons for these outcomes or these connections, I think it's likely to consider that without having gone through this process in our own lives, it's probably much harder for us to talk about it, right? If we've really evaluated, though, what our own wishes and our own values related to our own future care is, it makes it more translatable to the people that we're taking care of. And I think it's also important to highlight that it's not just about the completion of documents, right? It's more about how well we've communicated those wishes to the people who are likely to be caring for us, whether that's family and or providers. And you can see in terms of connections with professional practices, all 4 of those were connected. Scores were higher in effective end-of-life care delivery. They were higher for patient and family-centered communication. And those who had communicated with family and providers were more likely to refer to palliative care and hospice. And there's a note here that palliative care was, let's see, I'm trying to remember which one of these, significant for communication with family, not providers. So those who had communicated with family were more likely to refer to palliative care, but those who communicated with providers were not for that one. So I wanted to provide a quick resource to you all. Now that we've really just, I think the research that I described really shows that people who have completed and thought about their own advanced care planning are really doing a better job and showing higher scores on outcomes such as patient and family-centered communication. And so I think it's important for us to encourage professionals to think about this for ourselves. And the Conversation Project is a great resource for that. If you're not familiar with it, I'd just suggest that you look it up. And the Conversation Project is not about the completion of documents. It's not about the documents. It's about the process of thinking about values and wishes and how to have the conversation with family members. So I just have a couple of screenshots showing some of their resources, but I'd suggest you just take a look at their website as well. And it walks you through this process of who you would like to talk to and when a good time might be to talk. And then it also gives some suggested phrasing for how to bring up this conversation in your own lives. Okay, so I've got a short video. Here's where you guys are all going to wave like maniacs if you can't hear this from my computer. Bummer. So you guys can't hear that. Could you hear it a little bit or not at all? Not at all? Okay. Well, I can certainly forward you guys my PowerPoint so that you all have these if you want to watch these. But we'll just move on since I don't want you to just be seeing a video with no audio. So thanks for that feedback. Okay, let's see. Great. Okay. So moving forward then, I want us to talk about more of the logistics about when we're talking with families, what are these documents that we should really be familiar with? And how can we really do a better job having these conversations? I think it's important to recognize that 85% of us, we looked at some of the trends, and I think we know that most people die with chronic illness, but 85% of us die without the capacity to make decisions. And so it's really important. I think that alone is one of those reasons why it's really important for us to think about advanced care planning and advanced directives. But the majority of seriously ill or terminally ill patients actually lack advanced directives. And advanced directives are essentially a written document that states a person's wishes regarding his or her medical care when the person is incapacitated or cannot communicate. I think one of the fears for people when they're first presented with an advanced directive is that it can jinx them, or if I fill this out, then am I saying that this will happen? Or that completing a medical power of attorney means that I'm giving away my rights to make decisions for myself, which obviously none of those things are true. And I think the starting place is having conversations about what these advanced directives actually mean and what they can do for people. But advanced directives can also include informal directives, such as letters or conversations that communicate preferences, right? So it's, and here's a couple of examples of those. Right, so we have the living will, which is a map that talks about or instructs healthcare providers about what one's wishes might be. I also think the living will is a map for family members, which is, again, why those conversations are almost more important than the document itself, right? Because you can have a document that's filled out by someone, but without real conversations and communication about the values and the wishes that went in creating that document, families can still really struggle with making decisions for a loved one who can't make decisions for themselves. And obviously there's the durable power of attorney for healthcare, which is the designating someone to make decisions for you if and only when you're unable to do so for yourself. And then the out-of-hospital DNR, which I think in Missouri, and I'm from Texas, so I practiced in Texas, but I've been told here in Missouri that it's purple. And this is basically, it's a medical order that indicates to emergency professionals that someone is a DNR or do not resuscitate. And it basically protects them when they're at home or when they're traveling, or if something were to happen to them from being resuscitated if that's against their wishes. Some of the problems related to advanced care planning is that often advanced directives are not done at all, right? I think we talked about that a little bit earlier, in that many people living with chronic illness have not implemented these documents, and I think that's true for professionals as well. Sometimes when they are done, they're not done very well. They're not done with much conversation surrounding them. And then even when they are created, they're not always followed. Maybe we're not always aware that they're on the chart. There's lots of research that looks at outcomes and actions versus advanced directive documentation on charts, and those things don't always match up. And sometimes there can be a limited use for some of the documents, which is again why I think when we think about advanced care planning, we should think about more than just the documents, right? And that the conversation and the communication and the understanding that goes into all of that, it should be primary. It's also, I think, important to recognize the POLST paradigm, which is fairly new. I don't know how many of you are familiar with this, or if you all are seeing this in the hospitals that you're working in here in Missouri. And in Missouri, you'll see it's called the TPOPP rather than the POLST. Show of hands, anybody who's heard of this or seen this? So really nobody, from what I can tell, maybe a few. And we were having this conversation with several physicians here yesterday, and they were wondering whether or not this is being seen here in Missouri much. But basically, the POLST is not meant to be, or I'll use TPOPP since that's what we'll see here in Missouri, is really not meant to be a replacement for advanced directives like the living will, the power of attorney. the out-of-hospital DNR, but it's meant to be kind of a single document that is actually a medical order. So rather than the living will, which talks about preferences, this is actually a medical order signed by a physician that could translate across, you know, from nursing home to hospital, across locations, right, or settings. To learn more, there's a website that you can go to that I've just included in the PowerPoint for you guys to look at. But really, this is, when we talk about advanced directives being for anyone, and being for people who are not living with chronic illness, right? Because I certainly advocate for people of all ages to think about, have conversations, and do their advanced directives. The POLST, or the TPOPP, on the other hand, is generally for patients with serious health conditions, right? So because it's a medical order, these are for people who are chronically ill, living with chronic illness, and they want to avoid and or receive, or not and or, but or receive any or all life-sustaining treatment. So they've thought about their wishes, they've completed their advanced directives, and then they really want something that will protect them. And often it's for people who reside in long-term care facilities or who require long-term care services. And it's likely, I think, the judgment for someone who should have this particular document, it might die within the next year. So if we're comparing the TPOPP with advanced directives, what are they, why are they different? I mentioned a few of these points. The advanced directives, healthcare proxy, that's for all of us, for everyone, regardless of where you are in an illness process. Again, thinking back to that advanced care planning chart, that we should start with documenting our wishes while we're healthy, right? We're completing this for future. It's not really in effect until we've lost decision-making capacity related to at least healthcare proxy. And there's no medical order in any of those advanced directive documents except for the out-of-hospital DNR, which is good for people who are living at home. But also, the advanced directives may not be available in all settings. So someone may show up to the hospital and not be able to, you know, be in an incapacitated state, and the hospital may not have a copy of those advanced directives, right? The TPOPP, on the other hand, is for people who have chronic progressive illness or may die within 1 year, and it applies to a person's current condition, current situation, rather than potentially in the future. And it's not conditional on decision-making capacity, and it's actually a medical order signed by a physician, and it's meant to accompany the patient across settings. I have a video here that we can't watch because you guys won't be able to hear it, but this was a video from Kansas City, Missouri, and really talks about TPOPP within Missouri. So it's useful. It's about a 4.5-minute video. And I can, again, share this with you all so that you can perhaps go back and view the video. But the success of POLST, there's been studies looking at, is this really necessary? We have advanced directives. Is this kind of newer document useful? And this study was done in 2011, and I think there's probably some more recent ones now at this point, but they did a study looking at the POLST document in nursing facilities in Wisconsin, Oregon, and West Virginia, and they found much higher consistency rates between the treatments that were chosen and the POLST orders versus studies that have looked at advanced directive wishes and kind of actions that actually occur. So POLST orders were consistent with treatments provided 94% of the time. So again, it's one of those things, I don't know when and how and where exactly it'll catch on, the TPOPP, and but I think it's important to be aware of it so that if we have people who are using the TPOPP, that as clinicians, we're aware of what they are. Some criticisms of POLST documents should be made clear that completing is always voluntary, and it can certainly be revoked. Same, with advanced directives. And it really is not meant to replace, right? Because advanced directive documents should be started much earlier in the process, and advanced care planning should be ongoing. So it's really meant to complement and be something more specific for chronically ill patients who really want to be sure that their documents or their wishes will be implemented, rather. And within the POLST document, there's a poorly defined recognized decision maker. Direct power of attorney or legal guardian only, that's not really very clearly defined. And here in Missouri, I've learned since living here that there's no legal definition for who constitutes next of kin. In Texas, there was kind of a legal definition for the order of that. And so I think that's just another reason why advanced directives are so important, but is one of the criticisms of POLST documents. And then, does it provide legal protection for a healthcare provider to follow an order that comes in? And that's been unclear. Overall, challenges to implementing both advanced care planning and advanced directives is that often people aren't ready to have these kinds of conversations. And while we want to introduce them, sometimes families are resistant to them. Another challenge is that sometimes physicians or providers are not ready to have these conversations and or not prepared and or not properly trained or don't get enough practice. Or often we have different expectations about who on the interdisciplinary team should be in charge of this conversation. And ultimately, I think it's important for us to recognize that we each play a role and that there's never too much opportunity, providing too much opportunity for these kinds of conversations and communications to happen with patients and families. Maybe there's no identified healthcare agent or surrogate, so it's hard for us to figure out who the proper person is to talk with, especially if we have a patient who's incapacitated. Perhaps there's lots of cultural barriers and or functional health illiteracy that prevent us from having conversations about wishes. So really, who should be involved in advanced care planning? And it should be a shared process, right? And you know, I think anybody that's providing care to a patient and family has a role here in terms of providing opportunity for these kinds of conversations to happen. And then once these conversations are had, I think it's important to document, but share those wishes through the process of completion. Some places to start, you know, what are the expectations of the patient and family related to their care? What kinds of things does the patient value? The first video that we didn't get to watch showed the physician talking about with the patient, what does a meaningful day look like for you? And really how simple that question is, but how much can be gained from that in terms of thinking about quality of life for a patient. What makes life worth living most, or what really matters to you most? What's important to you today? Where are our patients and families focused in terms of goals of care and options? Talking about treatment, what that actually looks like, what the burdens that come with that are versus benefits, hope of recovery, what will life look like afterwards, whether that's surgery or treatment, et cetera. And really, I think also being able to educate about options for families and patients. And then ultimately supporting patients and families and their decision-making process, recognizing that it's not about what we think is best all the time, as hard as that is. It's really about what they think is best, and supporting them in being able to make an independent decision and an informed decision. Comprehensive advanced care planning also involves discussion of the disease trajectory, which again, we know is difficult across a number of chronic illness processes. But it's really important to think about and to talk about what patients can expect with their disease process. And that should be part of the conversation in our advanced care planning with them. And the goal is to try to make more proactive decisions and to really understand patient values rather than just reacting to changes in condition, which is, I think, unfortunately, how a lot of decisions are made based on timing, based on because these kinds of conversations can take a lot of time. I just want to wrap up by providing one potential model for how to have advanced care planning conversations. This is one with an acronym GOOD, so a good conversation, focusing on goals, focusing on options, focusing on opinions, and then documenting. So goals of care are going to be different depending on who you ask. And I think that's really important when working with patients and their families, is recognizing that each person brings something different to the table, and they all bring a different set of values, and they all have different opinions, and managing that can be quite difficult. But I think it's important to recognize that there's multiple voices at the table from the patients and family, and obviously wanting to recognize and support patient autonomy. But I think it's in terms of helping them communicate with one another is a big part of advanced care planning. So recognizing that the big picture helps identify clear and specific treatment goals, and really being mindful to talk to all the different key stakeholders so that everyone is on the same page about what those goals are. Options, considering all the available options, offering specific information, and doing a lot of education related to benefits versus burdens, success versus failures of specific treatments, and really counseling on what to expect in both near and long-term future. And again, trying to be on the front end rather than reacting to things. And coaching and educating so there are no surprises, and that people understand what their options are when a crisis appears. I think some of the things that we see related to end-of-life care is that we're often waiting for that crisis before we're making referrals or having those conversations. And often when you're in the hospital, that's what you see. But I think when we have opportunities to be talking early, that's what we should be trying to do. So opinions, providing clinical recommendations, taking into account current clinical situation and data, offering rationale and recommendations, yet also really being in tune with the patient values and preferences, and using impartial language to encourage best communication across and within families. And finally, documentation. So the 5 W's: who, what, where, when, and why. And I think the documentation is really important too when we're working in large interdisciplinary teams, so that we can have an understanding, because we are likely having multiple conversations with the nurses is hopefully having some conversations, the social workers hopefully having some conversations, physicians, and all documenting and communicating about those different conversations to really get a comprehensive picture of what's going on with the patient and the family, conveying options, decisions, plans, and future wishes. So in conclusion, the conversation really starts with you all, and I mean that personally and as well as professionally, and that it's important to have the knowledge about advanced directives, advanced care planning as a process, but also all of the different options that might be available for people, and hopefully the model that's provided at the end is a useful tool as well. This is you all here with your thumbs up. I will talk with patients and families early about advanced care planning and options for end-of-life care, and I will consider my own advanced care planning needs. So I've left, gosh, what is it? We go to 1, maybe 5 to 8 minutes if you all have questions or thoughts or comments or anything you want me to go over a little bit further. And I'm sorry my videos didn't work, but I'm happy to send this out to someone who can share it, so you all can go back and view those. I'm certainly appreciative of you guys having me to talk with you all, and my email address is here if anybody wants to contact me or has comments or follow-up or feedback or any of the above as well. Thanks so much for your time.
Thank you.
Thank you.